Thanks to all the audience who follows our broadcast. We are live on the third day of the 2020 International Web-Based Neurosurgery Congress. Remember, we're streaming on YouTube Live too. Well, now we have the honor today of having Dr. Michael Lee Levy. Dr. Michael Levy is a well-known pediatric neurosurgeon at Rady Children's Hospital, where he is the chief of pediatric neurosurgery. He is also the director of surgical epilepsy team and neurotrauma team in Children's Hospital, Los Angeles. Today, Professor Levy is going to share with us his lecture, Considerations of the Orbitozygomatic Approach in Pediatric School-Based Surgery. Type your questions in the Q&A section. We will read them at the end of Dr. Levy's presentation. Welcome, Dr. Levy, and thank you for sharing your lecture with us and for your time. The audience is all yours.
Thank you. I very much appreciate it. Today, I'm basically going to talk about a strange hybrid, which is the incorporation of what are classically considered to be skull-based approaches into pediatric neurosurgery. I'm really going to spend most of the time talking about craniopharyngioma because the orbitozygomatic approach really is something that the tumor lends itself to well. I work at UCSD and I have nothing to disclose. So what are kind of the important current considerations when it comes to craniopharyngioma specifically? I believe that extent of removal and complete removal is probably the goal. Incomplete removal or incomplete removal followed by radiation really aren't paths we can take comfortably in young children. And so open surgery tends to be our preference. Even with a complete resection, you can have recurrence. And it's not that uncommon that we do see that. Intracystic therapy, I think, is temporizing, but the problem is if you need to go do an open approach, it makes the surgery much more difficult and really disrupts a lot of the arachnoid planes that protect you from the important anatomy that really allow you to do the surgery. Educationally, it's a problem given that the vast majority of pediatric neurosurgeons aren't trained in skull base. I was kind of a hybrid in that I was a skull-based vascular neurosurgeon in addition to a pediatric neurosurgeon for 9 years. But that's an oddity. Most of the residents I work with that go into pediatrics, I encourage to do an extra year of skull base. So what is the answer? I really don't know that we have an answer, and I'm going to get into that throughout this talk. If you look at excision rates historically, we've really underperformed, and these are the most significant of people in a review of their series, and you can see that the excision rate ranges from approximately 18% to 90%. These are large series, but even at 90% with this type of tumor in children, that's just not good enough. So what are the potential approaches? These are all approaches that I've utilized in the past: subfrontal with a transbasal component, transnasal endoscopic approaches, terional, orbitozygomatic, or middle fossa. Also can utilize an interhemispheric approach. What I've done is I've tended to utilize either transnasal endoscopic procedures for a vast majority of tumors. For those tumors that are what I believe to be more difficult, I'll usually use a combination of orbitozygomatic alone or orbitozygomatic in conjunction with a middle fossa approach, a subfrontal component or an interhemispheric component. I mean, we do a lot of transnasal approaches from craniopharyngioma, and these are all cases that we've done via transnasal approach to give you a sense of the extent of tumors that we are willing to operate on via transnasal endoscopy. And I think whether it be solid or cystic, these do lend themselves very well to operative interventions. I think that the goal should be complete resection, and that's really why I think an orbitozygomatic approach gives you the best advantage to do this. And I believe this is the case in the most complex of tumors. So what are the considerations? I mean, the goal obviously with skull-based surgery is to minimize brain retraction and structural retraction while allowing for an improved corridor, an improved area of exposure. And this is done by bone removal. Displacement of bone allows one to get a better approach without displacing brain. It also adds an inferior component. So as opposed to like a terional approach where you're kind of looking laterally and down at the optic apparatus, you get that extra 17 degrees, say, over a terional approach. And this is data from 25 heads and 50 sides of measurements that we had done that really shows that once you free up the optic nerve, you can actually see the underside of the optic nerve. You actually get a better view through the lamina terminalis into the third ventricle. So I think this 17 degrees is an important component. What are other considerations? People have been modifying the approach. What is the extent of your orbital osteotomy? Do you do a two-piece or a one-piece? In kids, we tend to do one-piece approaches. Do you do a combined approach? Do you incorporate a subfrontal component, a middle fossa component, or an interhemispheric component? And then extradurally, do you use a Dolinck modification? Do you remove the anterior clinoid? Do you intradurally or extradurally? Do you free up the dura propria? Do you drill out the rhomboid construct to give you a better approach to tumors that are lower in the prepontine space? So what are the benefits of the pros? Obviously minimizes retraction, removal of the arch, once again gives you that extra 17 degrees of imagery and allows you to displace the temporalis muscle inferiorly, which helps. It really seems to shorten the distance and it gives you multiple routes. So you can take different attempts, different approaches, and it really extends your view into the third ventricle. And that's vitally important because for the larger tumors where I use this approach, the vast majority obviously involve the third ventricle, and getting a good view of the third ventricular structures are quite important. Also in being able to preserve the hypothalamus. It really has significant advantages. And I think that those are really the primary reasons that I prefer this approach over other approaches. What are the weaknesses? Well, there's a significant learning curve. You need to spend a lot of time in the skull-based laboratory. The more you do, the better you get, but it is something that takes a while to learn. The osteotomies don't. Preservation of frontalis branch adds a little more to the learning curve, but the actual surgical endeavor and the different approaches, whether it be a terional approach or orbitozygomatic, really based upon number of cases and number of exposure to this type of tumor. You can lose more blood, which is problematic for children. With mobilization of structures, as I'll talk about in a concept I call point reduction, there's obviously chance of injury to the carotid, injury to the cranial nerves. And then with regard to far posterolateral lesions, it's really not perfect. We published in 1996 about removal of the rhomboid construct, otherwise called Kawasi's triangle, to give us a better view for these complex tumors. I don't believe cosmetically there's a significant difference, and I think that I don't do Dolinck approaches where I skeletonize the periorbita, so we're not seeing pulsatile exophthalmos. And I'd say we're probably about 88 to 90% of preservation of frontalis branch. So cosmetically, I don't think there are any issues. Surgically speaking, I try to minimize the use of electrocautery, but you need to always remember to displace structures with the tine and remain perpendicular so as to not get heat spread. I prefer sharp dissection with the number 11 blade. My blunt dissection is with a bayoneted Ichiban dissector. I think you need to minimize your neural and vascular retraction, and that's the concept of point reduction. And once again, preserve the surrounding brain, which is what these type of approaches allow you to do. I don't aggressively manipulate the tumor. I tend to free it up sharply and let it deliver itself. especially anterior laterally where adhesions are common. And I try to attempt to preserve the arachnoid plane. The arachnoid plane really gives you the biggest benefit, especially for these tumors that are posterior and inferior, and these tumors that are lateralized, and the cellular diaphragmatic and mesencephalic components are present the first time around. In second approaches, or in somebody that's followed a radiosurgery, radiotherapy, or intracystic treatment, you lose those arachnoid planes, and I think that's why the compromise of second surgeries is much more significant than the first attempt. And that's why I think the importance of a complete resection needs to be attempted on the first attempt. So these are the considerations for an orbitozygomatic approach. And once again, the modifications, do you simply do a transzygomatic approach and remove the zygomatic arch? Do you do a modified approach where you're getting somewhat into the orbit? Or do you do what I consider to be a formal orbitozygomatic approach? And I prefer this for the vast majority of my cases, because once again, these tend to be bigger, more difficult tumors, tumors that I wouldn't historically do endoscopically. This is the salient anatomy, and really understanding this anatomy and the relationship of the chiasm to the third ventricle, the clinoids. All of this is really kind of important in allowing one to have the best chance at safely removing these tumors. Depending on the size of the tumor, there are 3 types of incisions, the smallest being a Fukushima type A, the second being a Fukushima type B, and the third a Fukushima type C, depending on the extent that the tumor is lateralized and posterior. And these are some basic pictures. When we open the flap, we always harvest the pericranium above the linea temporalis, and we use that to really get a better chance at a good dural closure. This is usually where we'll put our singular burr hole. Usually we'll use the high-speed drill to further take it down and free up the wing, allowing for basically this portion of the construct. I then use a hammer and chisel and will go through the orbit and free up the zygoma and then deliver this on block. And that allows for your approach. Approach is here you see the bone overlying the periorbita, just because I think the primary problem is that you can get a pulsatile exophthalmos falling if you aggressively drill. And so that's why I currently don't utilize that component of the Dolinck approach. Hypothalamic compromise. I think hypothalamic compromise is part of a learning curve. The problem with the hypothalamus is it's relatively avascular. It sucks like tumor. If you're using the ultrasonic aspirator, it will come up with aspiration, and it looks like tumor. Every case I need to sit down and remind myself that where you see the hypothalamus is usually exophytic component of tumor, and that for those areas that are adjacent to cyst capsule that look like tumor, you need to leave them alone. Everything's telling you to take that area because it looks like tumor, but you need to remind yourself that it's not. And in doing so, you can really improve your chances of not creating hypothalamic injury. I think this is really one of the most important components because hypothalamic injury is the real fear to doing big surgeries. If you can get to the point through the learning curve where you do enough of these surgeries that you're starting to flatten your rate of injury to the hypothalamus, then I think you're getting to a place where you can perform these surgeries and have better outcomes. The clinoid is extraordinarily important, and I think that removal of the clinoid is mandatory in these cases. We remove the clinoid extradurally, but it frees up that much more space and gives you just that much more access to these tumors, especially when you need multiple corridors between the optic nerves, between the carotid and the optic nerve. or even via some of the lateral triangles if you're doing a transcavernous approach. And here we're drilling out and removing the optic strut. And this is really the salient anatomy once you've removed the optic nerve. I like to drill out the optic canal, and so it really gives you a much better view. And then if you open up Pernetsky's ring or the outer ring of the cavernous sinus, you can get a more extended view. Here we would have stripped off the dura propria, and what you're trying to do is really maximize your view without it being at the expense of too much mobilization of the carotid artery, too much mobilization of the third order optic nerve. And so this is this whole consideration of point reduction. You're trying to, I guess, reduce the amount of movement at these points of stricture. For the carotid, that would be at the exit of the external dural ring or Pernetsky's ring. For the optic nerve, that would be the canal. I think these are vital in approaching these tumors. So the clinoid is basically attached to the body of the sphenoid by 3 roots. We remove the canal roof, we remove the optic strut, and we remove the clinoid. And that's done in every case. We actually think this is so important that we just published a study looking at the anatomy of the pediatric clinoid and the development of the pediatric clinoid. We measured things such as the base of the clinoid, midpoint thickness, length, and distance to strut. And in doing so, found out that from ages 0 to 3 to adult, the length increased by about 50%. This is biphasic, with the first period of growth 0 to 11 years, second from 16 years to adult. Conversely, the strut increased by 63% between the years 8 to adult. Variations in the morphology is about 15% of these cases, with ligamentous ossification usually presenting when they're greater than 3 years of age, and pneumatization usually when they're greater than 11 years. All of this really allows us to be better prepared in knowing what we're going to see and find and the advantages we're going to get by removing the clinoid. This is a pneumatized clinoid. This is a coronal after an OZ construct. And you can see the clinoid's been removed. Frontalis injury, really to prevent injuries to the frontalis muscle, you need to understand the superficial musculoaponeurotic system, or the SMAS, understanding the danger zones, and basically connecting lines from the tragus to the highest wrinkle of the forehead, or a line from the earlobe to the most lateral aspect of the eyebrow. These are the danger zones where you can potentially injure frontalis. It tends to be most vulnerable where it crosses the zygomatic arch. So usually we'll locate the STA, which is external to the SMAS. The temporal branch of the facial nerve is usually adherent to the underside. If you preserve the system, you're going to preserve the nerve. Also, to realize that the significance in splitting the fat pad is that the inner portion of the fat pad is very suckable and soft as opposed to the outer portion. Some people will end up really just splitting the outer portion of the fat pad. And I think you need to be deeper and get that true plane of differentiation to enhance your preservation of frontalis branch. And once again, here's where we run into the most danger with injuring the nerve. Is usually over the zygoma. And this is a youngster that has good asymmetry of the forehead. You see some wasting from the orbitozygomatic muscle work. And this isn't uncommon with these approaches. She has good symmetry. You can still see some reduction, but frontalis branch is definitely returning. She has no asymmetry with regard to temporalis muscle. He also has some asymmetry. Frontalis branch is returning a little bit more slowly in him, and you see some slight asymmetry with regard to temporalis muscle. So morbidity, basically we had temporary nerve weakness in about 33% of our cases. 7% had permanent nerve weakness. Atrophy we see in about 26% of our kids. And these are only in the pediatric cases, not in my adult cases. The dura propria. I think that opening up the dura propria just gives you that much more room to work. It's a simple enough thing to do. It's not associated with any significant morbidity. And once again, it's one of these points, conceptually, a point reduction where you're allowing yourself to mobilize structures to get the best view and the best ability to get a complete resection of these tumors. Additionally, opening up the CLINOCAROTID canal and opening up the carotid ring, or what we call the outer ring of Pernetsky. By freeing up this ring, much as we do for ophthalmic artery aneurysms, you just get that much more mobilization of the carotid. The carotid being basically restrained by the ring versus not being restrained just gives you that much more ability to work. I do this with sharp dissection. It can be compromised. I've had one patient that had a post-operative aneurysm form from my opening up of the ring and injuring the outer wall of the carotid. We looked at 25 heads and basically measured the specifics of the canal. So we now understand the depth, width, and diameter. And this also gives us a better sense of what we can and can't do when we're trying to free up the canal on the ring. I also unroof the optic canal frequently. I think being able to remove the clinoid and open up the optic canal really kind of removes completely from the ballpark the consideration of a prefixed or postfixed chiasm. If you're concerned about a prefixed or postfixed chiasm, removing the clinoid and opening up over the brow will really give you the best approach. And this was in our current series of 45 children. We found that the chiasm was prefixed in 4 cases, postfixed in 5 cases, and really normal in 36. Once again, the ability to really drill off the roof and free up the optic nerve made it so the prefixed chiasm, which was rare in our series, was not an issue. Middle fossa approach, once again, based upon lateral and inferior extent of the tumors. We've done a combined middle fossa approach with the children in this series. This is basically understanding the anatomy of the petrous carotid, Glass-Cox triangle, and Kawasi's triangle, or a better nomenclature basically being the rhomboid construct. And you can see here posterior wall of B3, greater superficial petrosal nerve, Glass-Cox triangle, which has been drilled out, allowing you to see the petrous carotid, and then the the rhomboid construct where Kawasi's triangle is. And there's Glass-Cox triangle and your rhomboid construct. And essentially gives you this view. So you get a much better view of the pons. You basically get to see the exit of 5. So everything about this is allowing you to get to these more lateralized, deep-seated tumors, where the other option is basically to try to free up through your approach and basically pull the capsule up. I'd rather do the sharp dissection under direct observation. And I think that this approach lends itself to that. And here's a patient, or actually a cadaver that's been drilled out. So in conclusion, with regard to point reduction, removal of the roof, removal of the clinoid and the strut, freeing up of the carotid canal and Pernetsky's ring, and movement and mobilization of the dura propria really made a big difference in our experience. Two other things I think that I should mention is the importance of the middle fossa approach really has to do with these cases where you get not only this posterior inferior extent which is involving the basilar, but especially in cases where there's calcification. These are cases I still worry that when I do endoscopically, peeling the calcium off of the arachnoid is worrisome, given if we get into big bleeding, there's really not the option to get good control through an endoscopic approach, though I will do some of these calcified lesions if there's less calcification. I think it's vitally important anytime there's a redo with a big recurrence, because you've lost your arachnoid planes, you've lost your protection, and you're going to be much more intimately involved with the pons and the basilar artery. And I think removing the rhomboid construct just makes it that much safer. And I've talked about maintaining the arachnoid planes because this is what keeps you safe during this surgery. Vascular anatomy, I think the primary point is the great deal of important vasculature comes from the underside. And so basically the underside of the optic nerves and the underside of the chiasm is where a lot of your important vascular access is with regard to keeping the optic nerve and apparatus alive. The reason this is important is if you are doing a terional or don't have a good view of the underside or the lateral aspect of the optic nerve, freeing up the tumor and pulling on it blindly is a dangerous thing to do. The capsule will deliver, you'll have very little bleeding, but you can tear these small vessels and really not see aggressive bleeding during surgery, but that can lead to visual compromise. I prefer that extra 17 degrees of exposure. I like the ability of being able to mobilize the optic nerve up and medially, being able to see the vascular structures and using the micro scissors or 11 blade to really free up of the adhesions so I can remove the capsule, get a complete removal in that region while doing so safely. Our recurrences with the OZ tend to be recurrences either on the medial wall of the cavernous sinus or the underside of the optic chiasm. And so now these are two areas that I really spend more time, given that this has been where most of our recurrences occur. So classification is difficult, and I think there's been many different ways that people have tried to classify these tumors. Hoffman, Sami, and Yazergil. I actually prefer the Yazergil classification because I think that gives a better sense of what I think to be the salient features, the issues that I would address that haven't really been aggressively addressed are conceptually posterior inferior extent of tumor and lateralization. Posterior inferior extent really helps you quite a bit with determining whether an endoscopic approach would be better, because these posterior inferior extending tumors really lend themselves well to an endoscopic approach. Lateralized tumors, not so much. When I have an aggressively lateralized tumor with aggressive involvement of the middle cerebral, I tend to do these open and not endoscopically. But you can see all of our classifications are basically topographical, whether it be with regard to the diaphragm, the third ventricle, tumor extension, or the stalk. So my modifications would really be including posterior inferior extent, lateralization, or even both. Posterior inferior extent, once again, being these tumors that head posteriorly and inferiorly. If it's inferior medially or even inferior lateral, this is where I think you can still get a good endoscopic resection. If it's a recurrence, that's where I would rather do an orbitozygomatic approach in addition to a rhomboid construct removal. Lateralization being the same problem, that this tends to pull me away from wanting to do an endoscopic approach and leads me into wanting to really do an OZ. This is what I consider to be lateralization. There's a posterior component here. You can see the involvement of the basilar. In a first-time tumor, despite the obvious involvement of the basilar, you're going to have your arachnoid membranes intact, and you can really get a good resection of these tumors, and you can free that up sharply. I wouldn't trust doing this case, at least in my hands, using an endoscope. On the contrary, when you don't have lateralization, but you do have this posterior inferior extent, I think it is beneficial to do a transnasal approach because I think you can get a real good resection of these tumors. This, once again, not so much. You have the posterior inferior component, but this lateralization would keep me away from doing an endoscopic approach. This one was just a large tumor, and despite the fact there was a great deal of inferior extent, I did this with an OZ. This was somebody that had been treated with intracystic chemotherapy, violated the arachnoid planes, had radiation, was an extremely difficult case. So my only modifications would be adding the concept of projection, lateralization, or both. Our current series is 124 patients. That's combining both our adult experience, which is 34 patients, and pediatric experience. Most of the adults are patients that I've followed up through adulthood, and some of which have had recurrences. Of 76 initial approaches, 18 were temporal polar approaches, 19 combined, and 39 were OZ alone. 48 subsequent procedures for recurrence, 12 were via transphenoidal, 5 were combined, 7 were by a redo OZ, redo terionals early on in my series in 14, and redo subfrontals very early on in my experience also in 12. I no longer use the terional or subfrontal approach. Outcome, we've been fortunate to date. We've had no mortality. Our gross total resection rate is slightly higher than most of the published series at 93%. Morbidity, new hypothalamic injury in 10%, exacerbation of existing hypothalamic injury is at 8%. And once again, with regard to learning curve, this is significantly diminished over time. When I was first doing these surgeries via big approaches, injuring the hypothalamus was not an uncommon occurrence, was not an uncommon morbidity. The unfortunate reality is in doing so, it made me more aware of what I could and couldn't do. It reminded me of those areas which were tumor and those weren't, and really gave me a better understanding of how to be aggressive in approach, but really maintain one of the more important considerations, which is not injury to the hypothalamus. With regard to vision, 55% remained at their baseline, 11% had exacerbation of the visual compromise, 34% had improvement of vision. With just the orbitozygomatic approach, and I'm not looking at the endoscopic approaches, it's only 16% of the time that I can preserve the entirety of pituitary function, and I've really done a pretty lousy job in maintaining pituitary function. I don't know whether it's I'm willing to sacrifice the stalk to get a complete resection, or it could be the origin being related to the stalk. But my experience, I don't do a good job of keeping the kids from becoming hypopit. Outcome, 78% of patients have some component of diabetes insipidus. When we do middle fossa approaches, we can get cranial nerve injuries, multiple nerve injuries in 2 patients. 3 patients had third nerve injuries. 2 patients had fourth nerve injuries. And 4 patients with seventh nerve injuries, 3 were transient, and 1 was permanent. And these are really based upon integrating the rhomboid construct into our approach, or being really too aggressive in our manipulation of the third nerve just prior to its entry into the porus oculomotorius in the lateralized component of these tumors. CSF diversion in basically pediatric cases is about 10%. So in summary, what's the best approach? Subtotal approach with radiation. I think that is buying the chance for recurrence. I think the morbidity from radiation is something that we really can't utilize because of our kids and the long lifetime of children. So subtotal resections with radiation really are not my preference. Is my preference the correct preference? I only think it is in the setting of my experience and my outcomes with regarding the approach to these cases. This is all surgeon specific, and if you don't feel comfortable with these approaches, or you feel much more comfortable doing subtotal approaches, and you have much less morbidity, then that's the appropriate way to proceed. I don't believe in intracystic chemotherapy treatment. I haven't seen this work, and when they do need a surgery, it adds to significant compromise during surgery. Total resection, I mean, problem is obviously increased morbidity, and you are buying a chance to increase morbidity and more specifically injury of the hypothalamus. I think if you can get to the point where you can preserve hypothalamic function, that really puts you in a great place to aggressively try to resect these tumors. I think the extent of removal is very important. One of the problems I have with our endoscopic endeavors is most literature is well below 90% resections. I think it's easier to preserve hypothalamic function. I think it's easier to preserve stalk function, but I don't like the idea of getting a subtotal resection just because we don't have adjuvant radiation as a potential therapy that we want to make use of. The last pediatric consideration is essentially that we're looking at children that may live another 60, 70 years. That's problematic. I like to try to follow these patients as long as possible, but the longer they live, the more chance there is for recurrence, and also the more chance there is for some compromised secondary radiation. We have very poor success in saving patients that have malignancies resultant from radiation, so we do everything we can to avoid it. Approach versus training versus pediatrics. I've mentioned that pediatric neurosurgery is becoming less and less and less of a mainstay of skull-base approaches to kids. I think most institutions are having the adult neurosurgical colleagues, and specifically the skull-base surgeons, do these type of procedures if they're going to do big procedures. I don't think that's the way it should be done, but I am a pediatric neurosurgeon, and I feel comfortable utilizing these approaches in that population. I'm a big advocate of endoscopy, but I waited until a lot of the literature was out before really embarking in endoscopy. I think to be good with the endoscope, you have to have a very good understanding of how to approach and resect these tumors from above, most notably a skull-base approach. And I worry when you're approaching them endoscopically, if you don't have that understanding and you don't have that experience. And I think it lends you to get into trouble that you could potentially avoid if you had that experience with true skull-base approaches. Modification to grading scales I've talked about, which is posterior inferior extent and lateral extent. And I've talked about the anatomic correlates of point reduction. I think the importance of combined approaches, if need be, and basically the middle FOSSA approach. What is enough? It's difficult to say really what is enough when it comes to approaches to removal of these tumors. You can obviously get the sense that my belief is that we should try to get a complete resection. Even with a complete resection, you can see recurrence, but that recurrence can be usually much easier to deal with. And in our experience, it tends to be medial wall of the cavernous sinus or underside of the optic apparatus, and endoscopically, we can usually affect a cure the second time around. I think enough is whatever you feel comfortable with. If you feel comfortable with these approaches, if you spent the time in the skull-base laboratory and have built up your case numbers, then I think this is the appropriate way to go. If you haven't done that, then you need to do what is safe and what you believe can most benefit your patients. In conclusion, I think there is a significant learning curve. I really noticed that not so much with the anatomic component, but really with hypothalamic injury and learning to avoid hypothalamic injury, which has been almost a 25-year experience of trying to learn how to do so. Pediatric neurosurgery may be problematic for complex approaches, and there are becoming fewer and fewer pediatric neurosurgeons that like to do big approaches to these tumors. Limited access to far posterior lateral lesions, I think, is when you really need to entertain idea of removing the rhomboid construct in the middle fossa. I don't think cosmesis is significantly decreased when compared to a standard pterional approach in children. It gives you an extended inferior subfrontal and inferior superior view. It gives you a much better view to the ipsilateral wall of the third ventricle of A1 of the inferior and lateral optic apparatus. And I think those are all really important considerations if you want to safely get a resection. Lastly, I try to minimize the use of bipolar electrocoagulation and really maximize the use of sharp dissection, both with the surgical microscissors and with a bayoneted or straight 11 blade. And just have found that this works very, very well in these scenarios. These are some cases that were done, and these were all done via open approaches, via interhemispheric approaches, orbitozygomatic approaches, combined approaches. Currently, this is a case I would do through a transnasal approach. But these are cases from basically the early to mid 90s. The approaches we would take at that time were translabial or sublabial. And I really didn't feel as comfortable with the sublabial microscopic approaches to these type of tumors. This is a tumor that we took out with Orbitozygomatic, and I obviously wouldn't have entertained a transnasal approach. Another tumor with a complete resection, one that I would do endoscopically currently. This one, given the involvement of the middle cerebral, I think that I probably would have attempted endoscopic approach, but if I would have gotten into adhesions and had some worry about the middle cerebral involvement, I probably would have punted and left some residual. This was a very lateralized tumor, and I did a combined OZ interhemispheric approach, and you can see the callosotomy here. This was that large tumor I'd mentioned before. This was done through a standard OZ with a middle fossa approach. We removed the rhomboid construct in this case, and we got a complete resection. This is another case that was done through a standard Orbitozygomatic approach. This is one that I would currently do endoscopically. This is another one that I would currently do endoscopically. This is an approach that, because of the calcified and solid components, we did through an OZ approach and got a complete resection. This was another approach that we took an OZ just because of the weird relationship of the cystic and solid components. It was a heavily calcified tumor, and I thought that that was the safest approach. This was another case that we took out through an Orbitozygomatic approach. This was an approach that I would have done currently endoscopically. And this was a case, once again, I would currently do endoscopically. You can see the swelling from an Orbitozygomatic approach, but you really don't see much retraction burn on the brain. You can see a little bit of evidence of retraction here, but the amount of bony removal really allows for minimal retraction of the cerebrum. I hope that this has been informative and given you a good insight in the way that I see these cases, and would be happy to entertain any questions about my experience or basically how I like to proceed with these cases. Thank you.
Thank you very much, Professor, for a wonderful lecture. I'm sure all the audience has learned from your robust experience, and they have some questions for you, Professor. Alberto Daza asks, in your experience, what is the incidence of enophthalmos after orbitozygomatic approach?
Of injury to the ophthalmic artery?
Of incidence of enophthalmos.
Oh, the early on experience when we were doing really kind of a standard Dolic approach and we would completely skeletonize the periorbita, we were seeing a combination of two things. If we would get a small laceration of the periorbita, we would get more significant swelling following surgery and chemosis. And with complete bony removal, we were seeing either an anophthalmos or exophthalmos, which was pulsatile. Once we've stopped removing all of this bone, that's no longer really been an issue. So as I've gotten farther away from doing a complete skeletonization of the periorbita, we really don't see that at all.
Okay, thank you. Juan Pablo Menguide asks, good evening. What do you use for attaching the bone flat?
We use titanium plates. We basically will use titanium plates at both of the osteotomy sites of the zygoma. We'll then have superior plates along the upper part of the bone underlying the linea temporalis. Remember, we do these in a singular construct, so it tends to be easier to place back into its anatomic position. We, depending on how we want to reattach temporalis muscle, because what we tend to do is cut temporalis muscle at the linea temporalis and flap it inferiorly. If we can suture it to the residual linea temporalis, we'll do that. We can make V holes and use suture and tie it up to that. Or sometimes we'll put some extra titanium plates and use the holes in those to tie up the temporalis muscle, just to give you a better cosmetic result.
Thank you. Georgios Miliares asks, regarding nerve dysfunction or injury, was that always noticed or sometimes this happens without noticing at all?
For optic nerve injury?
Yes. No, just general nerve dysfunction or injury. When I think about vision and visual fields, it can be very difficult in younger children. Younger children can present with significant visual compromise or blindness in one or both eyes, and this is something that just doesn't get picked up. They can have really significant field loss. I think it's vitally important to have a neuro-ophthalmologist do a real good exam before surgery and real good serial exams after surgery. And I think that's the only way you can really be certain that you are preserving function and not exacerbating compromise of the optic apparatus. As I've gotten away from pteriolan approaches and trying to free up and pull the tumor out from the underside of the chiasm, I think I've had less compromise to visual fields or vision. As I've removed the clinoid and unroofed the optic canal, I think that's allowed for more mobilization, which one, decreases the potential injury just because of that constriction where it enters the canal, but also gives you a potential view of vessels that you really don't want to take in removing that tumor. Thank you. Dr. Saiful Hook asks, does this approach is a good, or has a first option, is a good approach for craniopharyngioma?
This is, the orbitozygomatic is my primary approach. The way I approach these, well, I basically look at a case and determine, am I going to do it endoscopically or do an open approach? The obvious intent is to get a complete resection. Sometimes we'll do multiple endoscopies to get a complete resection, but those tend to be safe cases, and I'm happy doing that. When I decide to use an orbitozygomatic approach and do a big approach, it is with the sole understanding to get a complete resection. And the sole approach is to get as complete an exposure to every aspect of the tumor that you can, to get as complete an approach to all of the salient anatomy, to really obtain complete visualization, and kind of putting all of those factors in together, which allows you to potentially safely get a complete resection. Even in doing so, we're still just slightly above 90% in our resections. We still see residual. We then either decide to go back immediately with an endoscope or wait and see if it's truly scarring or residual. But I use that as my first line approach.
Thank you, Professor. What do you recommend about the medical and surgical treatment of intraoperative cyst rupture?
of intraoperative
cystic rupture?
Oh, it's difficult because if there's rupture of the cyst contents, and I think that's what you're asking, it changes the dynamics of the case. Where we've had our problems if people have placed catheters and tried to drain the cysts through basically a catheter reservoir, or have tried intracystic therapy where there's leakage from the cyst. In those cases, what you find operatively is that this really kind of clear and protective arachnoid plane is adherent and no longer protecting you. And I think that makes it much more problematic if you're working around the basilar artery, much more problematic if you're working around the third nerve. And I think losing these planes is problematic. So I think anytime you get spread of cyst contents, especially into the subarachnoid space, that can be a big problem.
Thank you, Professor. Paulo Sanchez asks, and I quote, Dr. Levy, outstanding lecture. Thank you for sharing. In your opinion, which criteria must be taken in account for offering again an orbitozygomatic approach in recurrent tumors after radiotherapy was done?
For tumors that have recurred, it really depends on where it's at and the understanding that the tumor is going to be much more adherent and potentially more vascular. I really kind of approach it with that thought process. We had a young boy that we did a orbizogomatic approach that we got a complete resection, who had a recurrence of his tumor basically in the suprasellar region 12 years after surgery. We went in and were able to get a good resection of the tumor, but in doing so, we created significant bleeding. It was very adherent to the vasculature. It was very adherent to the optic nerve. We did not create hypothalamic compromise, but we had a significant amount of blood loss that really became a big problem and made it a very difficult case. Given that, I think I may be leaning in cases have already had radiation to going back in with a bigger open approach. I think there's so many benefits to an endoscopic approach, but stopping and controlling aggressive bleeding isn't one of them. Manipulation and moving structures out of the way to get to bleeding points isn't one of them. Having bleeding points disappear around a corner isn't one of them. And I think I've learned the hard way that these tumors are a very different beast after radiation. And unless it's really a small tumor with not a lot of adherence to surrounding structures, I probably would do a big open approach to get out the residual.
Thank you, Professor. In case of hydrocephalus that develops, do you prefer third ventriculostomy or VP shunt?
All of these kids ended up getting VP shunts because we essentially in the approach do a third ventriculostomy because we're doing a surgery through the lamina terminalis, so everything's wide open. The third ventricle connects with the prepontine space. I think the problem with hydrocephalus is just that no matter what you do surgically to some younger children, they're going to develop hydrocephalus, whether it be a small surgery, a big surgery, a head trauma, a bleed, an infection. It's just a bigger problem in younger children where the surgical intervention in and of itself is enough to move these children into the realm of being hydrocephalic. I think the reason we're not seeing as many shunts is because the lamina terminalis is wide open and you have very good and direct access from the third ventricle throughout, but in 10% of kids, that's not enough.
Thank you, Professor. And there's a last question. Enriqueta Lucar Figueroa asks, and I quote, "Good afternoon, and big thank you, Dr. Levy, for your presentation. It is true that there's is a tendency in some site centers for adult neurosurgeons to do pediatric school-based tumor cases. Thus, regarding the future training of neurosurgical residents interested in pediatric neurosurgery, would you advise doing a pediatric neurosurgery fellowship and then a school-based one, or a school-based followed by pediatric neurosurgery?
I think it's a problem in pediatric neurosurgery, and I think there are so many things to do surgically in pediatric neurosurgery that having an expertise or an understanding of vascular and skull base is becoming less and less important, and especially since we have incredible skull-based colleagues and vascular colleagues that really have much greater experience with orbitozygomatic approaches and middle fossa approaches than I do. I was lucky in my training that I was able to spend a number of years with people that were very adept at skull-based surgery. My professors at the time were Taka Fukushima, Steve Giannotta, and Bill Caldwell. And it was just a very fortunate time to kind of learn these techniques and then stay on at the university and continue to practice vascular and skull base in addition to doing pediatrics. My residents and fellows that have done combined pediatric and skull-based fellowships, I think, are better surgeons and are doing bigger, better surgeries. It depends if you fall into a job that's going to lend itself to that. If you go to an institution that's going to have you do those approaches, or if the standard has been to give it to the adult surgeons. It's a difficult question. My fear is that if you don't keep on doing these procedures, you're going to not be as good as your adult colleagues, and then maybe it is appropriate to send them to your adult colleagues. I'm not at that point in my career, and I feel very comfortable with these approaches. But I think if you don't do a fellowship, if you don't spend time in the skull-based lab, if you don't do all the things that it takes really to understand the anatomy, because that's really the key to being a good skull-based surgeon, then it may be better to punt these either to adult colleagues or do less aggressive approaches.
Thank you, Professor. On behalf of CIEN, I would like to thank you again, Dr. Levy. This has been a wonderful lecture. We are really grateful and honored for your participation in the first IWBNC.